Hi everyone, this is Jamie Eberling from the Michael J. Fox Foundation, and you are joining our Hot Topics in PD Research webinar. Welcome. This is the second Hot Topics event that uses this webinar format, and we're really excited to hear your feedback on how you think it's working. Today our topic is cognition and Parkinson's disease, and we're very lucky to have an outstanding speaker with us, Dr. David Byrne. Dr. Byrne is a professor of movement disorder neurology at Newcastle University and honorary consultant neurologist for Newcastle upon Tyne Hospital Foundation Trust. He's director at the university's Institute for Aging and Health, director of Newcastle Biomedicine's Clinical Aging Research Unit, and a senior NIHR investigator. So thank you, David, for joining today.
You're welcome, Jamie, and hello, everyone.
Thank you. The goals of today's webinar are first to provide everyone with some basic information about the types of cognitive challenges that affect Parkinson's patients, and to talk about some of the things that the Foundation is doing to address this unmet need. Secondly, we'd like to leave you all with a call to action to contribute efforts to help us to better understand cognitive challenges in Parkinson's disease, but also to participate in studies to test new therapies. And we'll discuss this in more detail at the end of the call. Just a couple housekeeping items before we get started. With this new format with the webinar, all of you participants will be able to submit questions throughout the presentation by using the Q&A box that's at the top right of your screen. You can just type in your question there, and hopefully we'll be able to answer it at the end of the call when we do questions and answers. If we're not able to get to your question, we may be able to follow up with a question and answer session that we'll be doing with David for our website. Today's presentation will last about 30 minutes for the first part, for the slides that David's going to be presenting, and then hopefully we'll still have 30 minutes left at the end for questions and answers. We're especially excited today because we've had a really good response. We had over 900 register to participate, so that's very encouraging for us, and thank you for all who registered. So before I turn things over to David, I just wanted to say a few things about what the Foundation is doing in the area of cognition. We're very excited about the research that's going on in this area. There's a lot of really good research that's going on, and I think that the field is moving forward. And over the years, we've really come to realize how common cognitive challenges are for Parkinson's patients, and we're very committed to addressing this, what we see as an unmet need. And it's really become a priority for the Foundation. And one of the ways that we're doing this is by supporting research to better understand the pathophysiology of cognitive impairment and dementia. So to try to understand the underlying mechanisms that are causing cognitive challenges and cognitive decline in Parkinson's patients. And by doing this, we can identify new potential targets and hopefully develop new therapies that ultimately translate into new treatments. In addition to trying to learn about underlying mechanisms and identifying new targets, we've just begun a big effort to try to determine the best way to measure cognitive change in Parkinson's patients. And this is important for clinical trials because we need to be able to measure whether a drug is working or not. So we need to be able to know if a drug is having the desired effect on cognitive function. And David's going to tell you about a major effort that the Foundation has just undertaken in order to address this. So I'm just going to put up the agenda for today. I'm going to turn it over to David in a minute, and he will introduce you to cognitive challenges in PD and tell you exactly what we mean by that. He'll also take you through some research to develop new treatments, and then he'll talk in more detail about two studies that are currently underway. And then at the very end, he'll tell you how you can help and how you can personally participate in the effort. And then we'll turn it over for questions and answers. So David, without further ado, I'll turn it over to you.
Thanks very much, Jamie. Well, hello everyone, and I wish I could be with you all. You just have to imagine that I'm going to be maybe in your living room, your kitchen, wherever you're actually logged into. It's always very difficult not to be able to see someone face to face when you're talking about things. And obviously the issue that we're going to talk about today, cognitive challenges and using the D word, dementia, a little bit here. It's a pretty emotive topic, and I know that it can cause a lot of anxiety and it can cause a lot of distress to people. It can also, paradoxically, I think, lead to sometimes a little bit of relief, because people want to sometimes have an explanation for problems that could be going on with the person with Parkinson's, and actually to have a rational explanation as to what's actually happening can sometimes lead to quite a bit of relief as well. And the general take-home that we would really like you to get at the end of this, and after that wonderful upbeat introduction by Jamie as well, is that we would like to hopefully debunk some of the myths during this next hour. We would certainly like to alleviate anxiety, and we would certainly definitely like you to leave the call with a feeling of hope. Because whilst bodies like the Michael J. Fox have given this a real priority, I think there's an absolutely excellent chance that we could come out with some new treatments that can be pushed through in, the next few years. And that's what we've got to aspire to. So if we just have a little look at the overview and what's the scale of the problem, I think that those of you who are sat with Parkinson's and those of you who are carers of people with Parkinson's will understand that there can certainly be some relatively minor symptoms that can occur. Perhaps they've been there from a pretty early stage of people with Parkinson's. In fact, when you look at it in a more detailed way, that can be around 40% of people who are just newly diagnosed can have subtle changes. It probably is only picked out a lot of the time on detailed testing, but it can sometimes show itself in day-to-day activities. Now, in a way, we've been victims of our own success, because way back when, people with Parkinson's used to literally curl up and die because they didn't have any treatment that was effective to treat the motor symptoms. And as you probably sitting there now realize, there are some pretty good drugs now available to keep you more mobile and to avoid that. As a consequence, James Parkinson himself never recognized dementia as part of his condition because people simply didn't live long enough in that era. So as we've been better at treating the motor symptoms, it's allowed other problems to emerge. And sadly, it has appeared that dementia is quite common in people with Parkinson's and will be 6 times more likely to develop compared to someone of a similar age without Parkinson's. But it has to be emphasized that age, getting older, is the biggest risk factor for this problem. So like dementia is a big societal challenge across the board, whether you have Parkinson's or not, age is also a big determinant of whether you get dementia with your Parkinson's as well. And like a lot of things, and Jamie alluded to this in her introduction, the rate of problems and the rate of cognitive decline is incredibly variable between people. And if you look at the different nature of the dementia syndrome and the associated features, there is a huge variability, and that almost certainly is because the underpinning pathophysiology differs from person to person. Now, the challenge we face is that at the moment we do have treatments, so let's not leave you thinking there's nothing that can be done, because I'm sure some of you will already know that there are drugs, and these drugs are variably effective. Like a lot of things, they work better in some individuals than others. In some people, they're better tolerated than others. But there are licensed drugs, and these can settle some of the positive features of the dementia problem. For example, associated hallucinations, they can improve alertness and so on. But we have to be honest, they have shortcomings. And as you see on the slide, there are no disease-modifying treatments, sadly, just at the moment, to try and put the brakes on. And that's what we're going to try and have to do in years to come. Recognize the fact that people are at high risk, to try and pick out those high-risk cases and give them at an early stage the drugs that might slow things down. So on the next slide, we're looking at the need to improve the recognition and diagnosis. And in a sense, this is self-evident, because you will realize that in the list of side effects that are listed in your medication packs, there can be some problems that initially the well-meaning physician or even you yourselves as the patients and the carers may think, oh, well, it's down to my drugs. It's nothing due to anything else that's going on underneath. And that may be the case, but it may be a harbinger of this cognitive decline. Now, the other thing that compounds it is that sometimes, and I'm not saying this is the case across the board, but sometimes your physician will concentrate mainly on the motor aspects, and they don't routinely assess cognition. And there was a slightly worrying statistic that I've put down here, and you'll be pleased to know this is from the UK rather than the US, but only a third of people, when they applied specific criteria to a big outpatient cohort of people with Parkinson's, only a third had actually been recognized and diagnosed with dementia in that clinic cohort. So in other words, 2/3 of people had the dementia but hadn't been given that label and hadn't been diagnosed as such. Therefore, they perhaps didn't get the benefits of, for example, being prescribed the right medication, having other medications adjusted, being given support, education and advice. And again, I know it is very country specific, but sometimes having a formal diagnosis of dementia does lead to access to specific services and welfare benefit and related issues. And of course, it does help one plan in terms of medical, legal, and also personal, societal issues, future planning as well. So I think there's a lot of need, and this is a major thrust at the moment, to improve the recognition and the diagnosis. So when we come on to look at the symptoms and the progression of the cognitive challenges in Parkinson's, the symptoms that are listed in the box on the left there are perhaps recognizable immediately in some situations. So, I mean, when in a sense you think of dementia, one often thinks of memory loss. They almost seem to go together. Now, the reason for that is actually the link that people think of with Alzheimer's disease, because of course that is it's a sort of prototypic dementia where people characteristically lose memory. Now, I would actually emphasize that in Parkinson's dementia, the memory loss may not actually be so prominent at an early stage, and indeed could be a latish feature and not necessarily a massive feature. So, in other words, you can have dementia with Parkinson's, unlike Alzheimer's, where memory loss is not so prominent. On the other hand, the next two bullet points, the executive problems and the visuospatial impairment, are more characteristic of the dementia with Parkinson's disease. Now, what do we mean by executive problems? Well, you may have got up this morning, you may have been putting on the toaster, you may have been making a cup of tea and trying to hold a conversation. In other words, multitasking. And, this business of trying to do several things at once or planning events ahead are all executive functions, high-level functions, and they are characteristically quite impaired and affected in people with Parkinson's dementia, as indeed is visuospatial impairment, so difficulty, in other words, of negotiating space, of being able to put things together, of being able to, if you're asked simply by the physician to say draw two overlapping pentagons, people would have perhaps difficulty with that, or copying clock face. So the tests that you're asked to do sometimes on assessment of cognition reflect that impairment. Language is often quite well preserved in Parkinson's dementia. It can be difficult with sometimes finding words. We all have that, and perhaps I'll have it during this call. But certainly word finding can be an issue, but it's not a major issue. What can be quite dominant, and again this probably resonates with some of you on the call, are the neuropsychiatric problems. It's almost that the features go hand in hand. And what do I mean by these? Well, we're meaning hallucinations in the visual modality in particular. a feeling perhaps as if there's somebody over your shoulder, that something might have gone across the floor, or that you're actually seeing perhaps your deceased dog or a relative or a friend in the room seems very, very real. That can be really spooky to the carer. That can be a real problem because people think, I'm going mad, what's going on? And this can be part, not invariably, it can be drug-related too, it can be infection-related, but it can go with the territory of dementia and Parkinson's. As can delusions, which can be very upsetting for the carer, where, for example, the person may feel that the spouse has been replaced by an imposter, or that they're having an extramarital affair. And this is where insight is lost, and it's where really management can become very, very challenging, and it leads to a lot of strain in the domestic situation. I put in gait difficulties and falls late in the day because one of the anticipated callers asked about gait difficulties and problems with cognition. And interestingly, certainly there have been some associations with, for example, freezing of gait and executive dysfunction. Not necessarily frank dementia or full-blown dementia, but there has been an association made where people with Parkinson's and executive problems are more likely to have freezing of gait. So the two are not independent, the two can be linked together. Now, as Jamie's really alluded to, one of the challenges that we have is not only just will you do an assessment of somebody in the clinic with Parkinson's, but actually how do you then best monitor the person with the cognition impairment in Parkinson's. And this would be a huge step forward, because if we gave you a drug, for example, we would like to know that it's doing you some good. You may say it's doing good, and that would be great to hear, but it would be really, really nice to measure that. And of course, that's what companies particularly want, because they don't want to be using insensitive instruments. And we'll come back to this in a later slide. Now, if we just move on, one of the questions that was again sent in advance, and this slide is designed to address that, and I hope it doesn't look like too much like hieroglyphics, and I'll walk you through it, was this relationship and the confusion that can arise over what is Lewy body dementia? What is dementia with Lewy bodies? Do I have that? So if we just look at this slide, the simple way to look at it is to look at the long orange arrow down beneath the boxes. So in other words, the arrow corresponding to Parkinsonian features. Now, if you've had Parkinson's disease for more than 12 months, and you see the vertical arrow drop down there, so if you've had your Parkinson's, the motor symptoms that is, for more than 12 months, and then cognitive impairment and dementia becomes apparent, the nomenclature at the moment, the convention at the moment, is that you would be said you would have PD dementia, or dementia associated with Parkinson's. Now, if your dementia began within the 12 months window, and often that would occur with some Parkinsonian features, although they can be quite subtle, and if you, in addition to that dementia, had, as you can see, some problems with fluctuating cognition, in other words, your attention span varies from minute to minute or hour to hour, often associated with visual hallucinations, if all that was going on within the first 12 months, then the current classification is that you would be labeled as having dementia with Lewy bodies. Now, the term Lewy body dementia, as you'll see at the very top part of that slide, the bracket covers both. So in other words, if you have dementia with Parkinson's, or you have dementia with Lewy bodies, you have a form of Lewy body dementia. So I hope that the slide clarifies that relationship, and this is the international accepted classification at the present time. So I would imagine that most of you on the call perhaps have had Parkinson's for a number of years, and if some of you are on the line who maybe have been diagnosed with PD dementia, then the odds are I'm mainly talking to people to the right-hand side of that bar. So if we move on to what causes dementia, and again this was stimulated a little bit by some of the really excellent questions that we got in advance of this webinar. The cause of dementia, I put the Rubik's Cube on because it's almost, the way I think of it, is almost in a matrix. I've said before that there's variability between individuals. You're all your own person. Everybody's individual, and that's the same as the basis of the dementia. In this, it's a variability, and think of it in 3 dimensions, almost like a Rubik's Cube. It could be variable on the degree of neurochemical abnormality. There are many different chemicals that can be affected and may contribute towards cognitive challenges in Parkinson's, but one of the key players is a chemical called acetylcholine, and we've had quite a big interest in that, certainly in my unit. But there are others, and that can be variable in terms of the deficiency. The second part of the matrix is the neuroanatomical basis, in other words, where it is. And we all know that the covering of the brain is affected in something like Alzheimer's, and indeed it can be in PD dementia. But we also know in PD dementia you can have problems primarily with the deep grey matter of the brain, in other words subcortical structures, whereas the cortical areas are relatively spared. So again, there is a great variability there. And then finally, the what it is, not the where it is, but the what it is, the neuropathological basis. And again, I think many of you will have heard about Lewy bodies, and we talked about it in the previous slide about dementia with Lewy bodies. But of course, Lewy bodies are the characteristic inclusion that's found in people with Parkinson's as well. And Lewy bodies can be in the brain stem, where they cause motor problems, but they can be in the covering, the cortex of the brain as well, and can cause cognitive impairment too. But we mustn't forget that there is also other protein aggregation going on in the brain of people with dementia and Parkinson's. And Alzheimer-like pathology, and here the 2 classic culprits are the Alzheimer plaque, particularly more so than tangle. These can interact probably with the proteins in Lewy bodies, and the 2 conspire, if you will. The problem that ensues is greater than the sum of the parts. They conspire to perhaps cause a dementia problem, so that in one individual the Lewy body could be almost solely responsible, while in another you could have the Alzheimer plaque being a big player, whilst in others it could be an admixture of the 2. And in the background there are relatively unquantified vascular contributions, little mini-stroke-like problems, if you will, that could contribute, and that's a relatively under-researched area as well. So against that backdrop, we've clearly got to now look at how we go forward in developing treatments. And one of the things that's been terribly frustrating, and you've probably read about this in the press, about companies, big pharma, pulling out of certain Alzheimer products and Alzheimer's research and neurodegeneration in general, is because of the frustration they've had in trying to translate animal findings and promising molecules into human studies. And it's a hugely costly process. So the way that we've got to get things moving again and unblock that pipeline of drugs coming through from the bench to the bedside is to improve our understanding of what causes the dementia in Parkinson's. And what I've given you in that very brief synopsis previous there is a sort of a working framework that we're addressing. We clearly need a regulatory path that is user-friendly, that get rid of the clutter, get rid of the red tape, so that we can push through things more quickly. I think this is a personal thing. It may lead to some questions and comment, but my own feeling is that a lot of people with Parkinson's would like to take part in studies. That's certainly the case in the UK. And what frustrates me is that do-gooders on ethics committees try very hard to feel that they're protecting your best interests and the person's best interests, but in fact it's counterproductive, and they're putting down an awful lot of blocks in the way. None of us want unregulated research, don't get me wrong, but it's a case of let's get on and make it a bit easier to put what could be a fairly simple proof of principle trial through without literally making the person go under with red tape and almost give up before they've started. We've both talked, Jamie and I, about tools for effective clinical testing, and I'm going to come on to that in the next slide. And then fund research on promising targets. There's a really exciting slide that we're just going to come to again in a couple of moments, where the idea will be to look at drugs that perhaps the company themselves may be a little uncertain about. They're not sure they've got the vim and the vigor to drive it through, not necessarily the funding. They may need a bit of help in accessing patients. Or it may be that funding research could involve looking at existing drugs that are out there and repositioning them. So in other words, a drug may have been licensed for one use, but there could be some very sound theoretical reasons why it might have an indication in another territory. So there could be a drug that's being used to manage epilepsy, for example, or to manage some kind of movement disorder problem, or to manage even an infection like tuberculosis. And it may be on theoretical grounds from animal models that may be seen to have some benefit, for example, in the management of dementia, and that would be a really bit of low-hanging fruit that could be explored again as a promising target. So don't be put off, don't be negative. There are many, many avenues to explore here. So Jamie very kindly mentioned in the introduction this importance of measuring cognition accurately. And the Fox Foundation have very kindly funded some research that I'm doing with them, which is also co-funded by our National Institute for Health Research. And this is an acronym, a mustard trial. It's a convoluted acronym, but at least it's a name that tends to stick. And nested in this drug study, which is looking at this agent called donepezil, is this really important study from that Fox are supporting to the hilt and funding to the hilt, which is to look at 4 available scales that have been used variably in the literature to try and work out which is best, quite simply, in measuring change in cognitive ability. And that study will not only look at the scale that seems best longitudinally, in other words, tracking change over time, but it will also look at which scale is the most sensitive to evaluating treatment effects. And it's very exciting because we're very, very close to starting with that now. I would hope literally within the next couple of weeks we're going to be up and running with this mustard trial and what we're calling the scales assessment study nested within that. So this is a fantastic goal that Fox have taken on, because at the moment, at times in the literature and at times when you're talking to pharma and industry who are interested in developing drugs, you feel almost like you're comparing apples with oranges. Nobody really knows which the best scale is. And this piece of work really has the potential to identify a scale that will have then widespread use in pharma and may well reduce the cost that they have to put into developing drugs, because they know the parameters that they're working within, they know what would be clinically meaningful, and that would allow them to power up the study appropriately. Now at this point, we're on to a new candidate for treating cognitive impairment, and I'm just going to turn you over to Jamie so that she can walk you through this slide.
Thanks, David. Yes, so this is a new partnership that the Fox Foundation has with the pharmaceutical company Sanofi. We announced this partnership earlier in the year, and we're very excited because this is a new type of endeavor for us, and hopefully not the last time something like this happens. But what we're doing with Sanofi is taking a compound that they were developing for cognition. It's been shown to be effective in several preclinical models and has been shown to improve different types of cognitive abilities, including things like memory. And we're going to be testing it in a phase 1b clinical trial. Now this is a compound, it's called AVE-8112. It's been tested in the clinic before, but only in normal volunteers. So this will be the first time that it's been in a patient, and we're very interested in seeing if Parkinson's patients who are taking Parkinson's medications can tolerate this drug, because you never know what's going to happen. You never know what's going to happen when you have different medications in a patient. So we'll be starting this trial. Hopefully by the end of the year we'll start recruiting. And really the aim of this trial is to assess the safety and tolerability of this drug. We'll be looking at cognitive function in these patients as well, but this is a small phase 1 trial, so we're hoping to get a hint about whether this could be effective for cognitive impairment, but really the endpoints for this trial are to look at safety and tolerability. Anyway, we're very excited about it, and the trial should start by end of the year or early 2013, and we should have the results available by the middle of 2013. And with that,
Great
I'm going
stuff.
to turn it back to you, David.
Thanks, Jamie. Yeah, this is really exciting stuff, and it is great to have something new on the on the horizon. So that's going to be something that we're going to look for with eagerness, and hopefully we'll get a slice of the action in the UK as well. So we're going to finish up here with how you can help. So there's a couple of things, how you can help yourself for starters. And one of the things that a question came in ahead of the webinar was about exercise. And this is a really topical thing, and so I thought that we would put in something little about take care of yourself today in collaboration with Fox. So we put down these items. Now, this isn't rocket science. Most of the things that are put down here are general health measures, but it's interesting because there's been some quite persuasive work done looking at how, if you looked at huge populations, the avoidance of obesity, eating a healthy diet, smoking, stopping smoking, control of blood pressure, for example, and exercising regularly would have on the population risk of a dementia like Alzheimer's. And as I've already mentioned, Alzheimer pathology can play a part in people with Parkinson too. So to me, it's a bit of a kind of an obvious thing that to just try and maintain these as best you can in terms of giving up your smoking and exercising as best you can are absolutely obvious to do. Now, the exercise one is particularly interesting because there have been some studies done, mainly I admit in the Alzheimer's side of things, but again, as I point out before, the pathologies are not necessarily totally separate, in fact far from. And there's some evidence being done that exercise can have, as well as general health benefit, some more direct influence on the amyloid deposition in the brain. So it can actually reduce amyloid in cerebrospinal fluid. It can reduce amyloid seen on PET scans in the brain. And that has been quite an interesting finding in folk when they've been stratified according to how much exercise they take. There's also some evidence that exercise could be help with neuronal sprouting and can cause nerve cells to actually regenerate to a degree. Now, I emphasize that this is all very premature, that there's it's animal model work by and large, so again, we're a bit skeptical sometimes of how that translates into man, but as a general health measure, taking care of yourself today, looking at these measures has got to be, I think, a good thing. And in addition, I put brain training because we don't know, again, that doing, for example, Sudoku and other puzzles and doing online games and so on, we really don't know whether that has any kind of major impact or has any prophylactic or preventative effect on cognitive decline. But again, just keeping yourself alert, keeping yourself engaged, to me is a first basic principle which is not going to do you any harm. So the other thing that's really important and is mentioned here is that Fox have sponsored or been involved in the setup of a trial finder. And there's details on the web link there that you will see, which is a way of enrolling into cognition studies, but also other studies to do with Parkinson's as well. And this is a really neat resource and one that I think you would do well to check out and just have a little look at and see how what would apply to you. The Fox website as well is an absolute rich source of information and certainly would be well worth checking that out too, just so that again you can be kept informed of recent developments. And so with that, I'm going to wrap up there on the presentation. We obviously are getting quite a lot of questions in, and I'll put it back to Jamie and colleagues to field some questions to me, and we'll try and get through as many as we can.
Okay, great. Thanks, David. That was really informative. And we do have a number of questions that have come in, but if you think of a question you want to ask and you haven't already done so, please feel free to type your question into the box on the upper right-hand side of your screen, and we'll try to get to it as well. So let's go with the first question, David. In what respects do the cognitive deficits in Parkinson's and Alzheimer's disease differ?
Okay, so I see one of the questions. I've just quickly ripped through the questions as quickly as I could as well. Somebody's asking about cognition. What do you mean by cognition? And maybe we should have made that clear, and I should have made that clear at the start. It's one of those kind of slightly woolly terms in a sense, but it basically comprises your mental functioning, your thinking, your interaction with the environment. So it embraces things like planning, memory, how you negotiate the environment, how you remember to get dressed, your language. It's a summation of all of those functions. That's what we're meaning by cognition. Now, because of the fact that the brain has different areas sort of assigned to different tasks, we know the pathology, the classic Alzheimer pathology, tends to attack the part of the brain called the medial temporal lobe, and that tends to cause problems with memory, short-term memory. And that's often not improved even when you give a cue. The language tends to go with Alzheimer's as well, so the content of the language becomes quite empty. And then in more full-blown forms, there can obviously be difficulty in negotiating previously familiar environments, getting dressed, and even basic functions in more advanced stage. Now, the dementia in Parkinson's tends to affect the executive functions more, which are more to do with the frontal lobes and the connections of, and also the parts of the brain involved in visual perception, visual spatial function. So the problems that I said in the presentation, difficulties with, for example, planning, dual tasking, double tasking, that kind of thing, where you're trying to walk and chew gum at the same time, to use a hackneyed phrase, but it's something difficulty doing that, difficulty getting around in familiar places, difficulty, in the clinic when you have to draw those overlapping pentagons. That's what we're kind of referring to there. Whereas the memory side in Parkinson's, although it can be affected, it's usually less obvious, not always, but it's usually less obvious, and can actually be improved by a cue. So it's maybe a retrieval problem rather than a registration problem.
Great.
So I'll wrap up with that one, Jamie, because I don't want to. I'll try and keep the answers, if I can, concise, so we get through as much as we can.
Okay, great. So we've had a few questions about deep brain stimulation and how deep brain stimulation might affect cognition, or are people with cognitive impairment even candidates for deep brain stimulation?
Right, okay, they're great questions. So the first one's easy to deal with. By and large, deep brain stimulation does not cause significant cognitive impairment. There have been a lot of studies done, some better than others. There are some mild impairments that are found on things like verbal fluency. So in other words, how many words beginning with the letter C can you name in a minute? In terms of actual impact on day-to-day activities and general cognition, general functioning, in other words, mental functioning, deep brain stimulation of targets like the subthalamic nucleus is not a big issue at all. By the same token, flipping it, there's no way that deep brain stimulation can have any benefit or good effect on preventing the onset of a dementia problem or a cognitive issue in a person with Parkinson's, because clearly it's targeting a separate circuit. So we've had people in Newcastle who've got a great result from DBS who sadly some years down the line have gone on to dement, but that's not because of their DBS, it's sadly because of the underlying condition affecting other parts of the brain. Now, the other half to the question was, is cognitive impairment a contraindication to DBS? The short answer is yes, it is. Again, it's all by degrees. If somebody had a diagnosed dementia with their Parkinson's, in this country, and I think, to be honest, in the US as well, it would be an absolute contraindication to deep brain stimulation. If there is a degree of cognitive impairment, sometimes it boils down to making out that the person doesn't have a severe depression that can mask the issue and can make them mentally function more poorly than really they are when they're not depressed. So that should be treated and addressed. But in mild cases of minor findings on neuropsychological testing, then that would be a judgment call, but is not an absolute contraindication to deep brain stimulation.
Okay, great. We had a question about the link between gait deficiencies and cognition. You mentioned freezing of gait. Could you comment on that in a little more detail?
Sure. I think that the relationship between gait and cognition is absolutely fascinating. And as I mentioned there in the presentation, there is an association between executive impairment and gait freezing. Now, sometimes these things are only picked up on formal neuropsychological testing, but it may be that people are online and they're kind of making the association that maybe the planning and the dual tasking is problematic, and that there are also issues with freezing. Of course, both would go with the territory of rather more advanced Parkinson's. The other aspect that I didn't mention, which is worthy of mention, is that one of the aspects of dementia in Parkinson's, or even a cognitive issue in Parkinson's, which is not yet full-blown dementia, is that attention can be impaired. And you may notice that if you've got somebody sat with you just now, their attentiveness, particularly to a call like this, they may be coming and going in terms of alertness. They may be falling off to sleep, seemingly waking up. And this may happen over minutes or even over hours of being more alert, less alert. Now, it may well be that those periods of poor attentiveness can contribute towards falling, because you can imagine, if you're not paying attention to your environment, that these little mini spells of switching off, losing attentiveness can actually lead to falling. And it's interesting that there was a study done quite recently in the States that looked at a drug called donepezil, which is a relation of rivastigmine. This is a drug designed to boost acetylcholine levels in the brain, seemed to lead to a reduction in the frequency of falls. And although that paper didn't address mechanism, it may be plausible that it was through increasing attentiveness.
Okay, David, you mentioned exercise and the beneficial effects of exercise. Is there a certain type of exercise that is best?
Yeah, that's a $64 million question, and I don't know the answer, and nobody does. The people have looked at kind of cumulative amounts of exercise. So, you know, one of the things that I know our exercise physiologists are really into at the moment when they're trying to train up people with, say, muscle disorders, and they think it might be also relevant for neurodegenerative issues, are what we call high-intensity programs, where you would do a relatively short session. You would do, say, a 2-minute warm-up, and if you're on a static bike, you would do, say, 30 seconds at absolute maximum, flat out. Then you would do 90 seconds of recovery, get your heart rate back down, in other words, and you would repeat 6 times, and then you'd do 2 minutes warm down, and that's the end of the session. So that's a really pretty quick kind of session overall. And there's possibly some evidence that the high-intensity bursts are beneficial. But whether that addresses the sort of disease-modifying issues that I was alluding to in the presentation about, say, reducing Alzheimer deposition, helping neuronal sprouting, we simply don't know the answer. Humans are not like mice on treadmills, and at the moment that's work that needs to be done.
Okay, another question. How frequently do you see cognitive decline in patients with young onset Parkinson's disease?
Right, okay, that's a great question. Interestingly, the thing that is the real crux of it is current age. That is the biggest determinant of whether somebody will have a cognitive issue or not. So in other words, if you imagine you draw a lifeline, so your birth to the left of your line and your death to the right of your line, and you have an arrow drop down at, say, 70. Let's say 70 because that's not far off actually the mark of a number of studies that have been done. You're kind of drifting into the high-risk area to the right of that arrow at 70. So you can imagine that if you develop Parkinson's at 68, then, you know, you've got kind of 2 relatively low-risk years. Then you're kind of going into that slightly higher risk where, because of your age, your current age, you're more at risk of the dementia developing, not inevitably, but you're just at a higher risk. Now, if you imagine you've got young onset Parkinson's and you've developed it, say, at 35 or 40, you're well to the left of that arrow. And so the expectation, by and large, not inevitably, but by and large, is that you would remain generally in pretty good cognition and cognitive health right the way through till that 70 years mark. And that is by and large how some of the ClinPath studies that have been done, for example, in London, would seem to pan out. So the expectation is not that it's a function of disease duration, absolute disease duration. It's actually more a function of current age.
We've had a couple people ask about Lewy bodies. You mentioned Lewy body dementia. Can you explain exactly what a Lewy body is?
Sure. So a Lewy body is named after Friedrich Lewy, who was a pathologist who described them in 1912. And a Lewy body is literally what's called an inclusion body. It's a membrane-bound inclusion within a surviving nerve cell. And it's composed of many, many different proteins. But one of the big important proteins in a Lewy body is a thing called alpha-synuclein. And many of you on the line, I know you're very well read, may have come across synuclein in your reading, because Parkinson's is sometimes called, in scientific jargon, a synucleinopathy. In other words, it's caused by abnormal aggregation and deposition of synuclein. And the synuclein may well be being sequestered or hoovered up, vacuumed up by these Lewy bodies, which may have a protective role. They may be cytoprotecting. They may be trying to stop the cell from being exposed to what would be otherwise harmful protein clumps, and they may be trying to protect the cell. So they are a hallmark of people with Parkinson's. They occur in certain areas of the brain much more commonly than others, and they are quite classic of the disorder. They may be good guys. They may be trying to prevent the cell from dying, and that's really, in a nutshell, what a Lewy body is.
Great. Is the LRRK2 gene related to a more rapid decline in cognition?
No, not at all. I mean, there have been some studies done looking at genetic forms of Parkinson's and the association with dementia and neuropsych. And I must qualify it because it's still relatively early days with regard to these genetic forms. And I know there's a paper just out recently that would suggest that even in people with LRRK2 mutations who have not been diagnosed with Parkinson's at the moment, they may have some subtle neuropsych abnormalities compared to non-mutation carriers. But generally, people with LRRK2 mutations do not suffer a higher frequency, a higher burden of cognitive issues.
Okay. How about a relationship between depression and Parkinson's disease and cognition? Is there such a thing?
Yeah, that's a really excellent question as well. So there's a lot of kind of issues related there. I'm kind of going to interpret it one way, and I hope this is the way the questioner meant it. So, well, so I'll deal with it two ways. So the first thing is that, interestingly, on the what can I do to help slide, I probably should have included depression in that and managing depression more aggressively. Because in the Alzheimer literature, there's quite a strong association between depression in later life leading on to dementia. If you like, it's a risk factor. Now, it may be that the depression is, if you like, a physical manifestation of the disease process as a prodrome, a forerunner of going on to develop the dementia. And perhaps by aggressively treating depression, there may be some mileage in trying to defer the onset of cognitive impairment. The second aspect to that question is that depression can be a real nuisance in terms of trying to assess cognitive function accurately. That's a crude way of putting it, but I think the audience may get the drift, because if you're very depressed, you can't be bothered. So if somebody's sitting there asking you questions, and it's a neuropsychologist, and they take ages, you often just can't be bothered. So it makes you look spuriously bad. And so one of the things that you always have to be careful about is that you don't misdiagnose somebody as having a dementia or a cognitive issue, where in fact it's a depression and an affective disorder, which of course can be more readily treated with antidepressant drugs. And the third aspect to that question is that depression is more common in people with a Lewy body dementia. So that's going back to that strictly correct definition that I said at the start of the presentation of people with dementia with Lewy bodies and people with PD dementia. They have a higher burden of depression than actually a number of other dementia syndromes, and that is something that can be readily treated. So depression is a common neuropsychiatric accompaniment of the dementia associated with Parkinson's, and it should not be missed. We should have a low threshold to be treated for that because it can certainly impact positively on quality of life.
David, you mentioned the heterogeneity in Parkinson's disease and with respect to cognitive impairment. Does every Parkinson's patient eventually develop some degree of cognitive problems?
It's not inevitable, Jamie, and I think it's a really interesting question. Certainly it is common. We have to be honest. Some of the stats I said earlier on may have been alarming to people, but, it is there. But I would flip it another way, and that is that I think we could learn a lot from, say, brain tissue donation from people who had had Parkinson's and who did not dement in life. Because you could argue that the studies that have been done, the Norwegian studies, there was a ClinPath study in America, there's been other studies that done, that 80% figure of people to develop dementia in association with Parkinson's is coming out as a reasonably consistent figure. But that still means that 1 in 5 do not. And what is it about the 1 in 5 that do not? And we need to maybe look at them, because it may be that in life we can learn things, and certainly perhaps through the gift of brain tissue donation we may learn in death as well, because there could be some aspect of their genetic makeup, there could be some aspect that we would learn through looking at their neurochemistry, through the pathology, that would inform us as to why they were, if you will, resistant to developing that complication in life.
Is there any evidence that caffeine or nicotine may help with cognitive issues?
Okay, that's a great question too. So caffeine only indirectly, because of the potential for alerting. There have been some drug trials looking at trying to help with the excessive daytime somnolence that people with Parkinson's can get. That might, in addition, help alertness, but there's no clear evidence that caffeine, to the best of my knowledge, can have a major benefit. Now, nicotine's a little bit of a different story, because nicotine works on our favorite chemical system, the cholinergic system. This is where I mentioned before about this acetylcholine, which is the chemical messenger in the cholinergic system. And there are 2 different types of receptor that the cholinergic system operates through. One is a thing called the muscarinic receptor, and the other is a thing called the nicotinic receptor. And so people have actually been looking at whether nicotine drugs can actually directly stimulate those receptors and can actually have benefit on cognition. Now, it's a very complicated area, because even within those receptors there are different types, and there are also issues in translating, as we said before, animal studies into humans. But that is a possible area of development to look at nicotinic drugs in the treatment of. Now, at this stage I could hear people rushing out to buy nicotine patches, but I would honestly have to say that at the moment that there is no evidence to support that expense or that usage, but certainly more targeted drugs, which would be more high affinity, as we say, in other words, they have a greater liking for certain receptors, are an area of development.
How do cognitive symptoms relate, if at all, to impulse control disorders?
Okay, well, the short answer is not hugely. There's no great evidence that if, for example, you have an impulse control disorder, you're at higher risk of going on to develop dementia. That's not been shown, at least again, not to the best of my knowledge. There have been some subtle abnormalities shown with executive impairment in people with impulse control disorders, but the reason for that may be not so much due to, if you like, a forerunner of dementia, but more due to the commonality of those problems with dopamine. So I know you're probably amazed I haven't really mentioned dopamine up to now, but dopamine may well be the mediator in that particular context between impulse control problems and the executive problems, because we know dopamine issues can affect both. And I think there's a lot more work to be done in uncovering, exactly what impulse control disorders are telling us, because they're common enough, but not everybody gets them. They're relatively recently detected. We've obviously had some great studies done in big populations, not least in America. But I think that there's no way that I would want anybody who maybe is experiencing such a problem at the moment to go away off this call worried that it places them at any higher risk of developing a dementia problem, because it does not. There's no evidence at the moment that would suggest that.
Okay, David, we're almost to the end of the hour, so I'm going to ask you one last question. Since you did talk about the Mustard trial and the comparison of the different scales, can you just briefly describe what the 4 scales are that are going to be compared in the Mustard trial?
Sure. So we've got, again, people on the line here may have had these given to them at some stage. They may not. There's a scale called the Scopa Cog, and think of Scopa Cog as the Dutch scale. There's the Montreal Cognitive Assessment. You can think of that as the Canadian scale. There's the PD-CRS, the Cognitive Research Scale, Cognitive Rating Scale, I'm sorry. You can think of that as the Spanish scale. And we've got the Mattis Dementia Rating Scale, which is the old man on the block and the sort of the one that takes a lot of time and the gold standard one. And what we're doing is we're looking at all 4 of those. So it's going to be a pretty long session for people who are being given these scales, and it's literally going to be done in random order. So, it'll be a case of putting 4, not done like this, but you can imagine having 4 playing cards, turn them over, and pick a card, and that's the scale you get given first. Because obviously you can imagine if you get given the same scales in the same order, then you're going to be at your sharpest on the first one, and you're going to be at your least good on the last one because you're more tired. So we have to jig the order around to make sure that it's totally random. And we're going to do a general global assessment of how people are using a kind of a semi-structured questionnaire to the person and their carer. And that will give us an anchor. So we'll have a kind of clinician's global impression as to how the person is, and we'll use that as the anchor against which we'll compare the scales. Of course, we'll be able to look at scale performance as well over a number of time points. And from all that data, from our 500 patients, we hope we're going to get that number over a 24-month period, we should be able to get a really clear idea which of the MoCA, the Mattis Dementia, the PD-CRS and the Scopa Cog are the best kid on the block, and we will be able to recommend one, we hope.
Great. It sounds like it's quite an international study.
It sure is, because we've got buy-in from people who are in the States. We've had fantastic help from a guy called, some of you will know, a guy called Dan Weintraub. Dan's co-PI with me on the study. He's based in Philly. He's been absolute star, really, really good wingman to have on that project. We've got Jaime Kulashevsky, who's in Barcelona, and he kind of instigated the PD-CRS. We've got Connie Maris from Toronto, and she's obviously done work with the Montreal Cognitive Assessment, the MoCA. We've got Ian McKeith, who works with me in Newcastle, who's had a lot to do with Lewy body dementias over the years. And we've got Glenn Stebbins, who's a really good neuropsychologist and a statistical whiz based in Chicago. So it's a really good international group that are kind of steering the study, with Jamie as well and colleagues helping keep an eye on us and generally help us out through the logistical field as well. I hope I haven't missed anybody off that grouping there, Jamie, but I think that's the international steering group as well.
Yeah, great. Thank you, David. And we are very excited about that study, and obviously we'll be following it closely. David, I want to just thank you for taking the time today to participate in this webinar. We've already gotten some feedback from participants, and they found it helpful, and we just really appreciate your time.
You're very welcome. You're very welcome, and goodbye, everybody. I I hope you have a good day, and I hope that the future is kind to you, and I hope that you are leaving this call with a feeling of optimism. It is great that Fox are reaching out in the way that they're doing, and I applaud that, and also the way that they're helping in terms of fund research. Obviously, I have benefited from that, but lots of other people are benefiting too, and it's an absolutely amazing thing that because it does help unlock issues, it helps unlock problems. They have a very can-do approach, and you don't always find that in research funders. And incidentally, just so you all know, I haven't been paid to say that. I just wanted to say that because it is very important.
I can vouch for that. Just a reminder to everybody, if you do have questions that weren't answered, you can still send us your questions, and we will try to answer those on our website. Also, please sign up for Fox Trial Finder, and if you'd like a link to the recording, we'll be posting that as well so that you can hear the presentation later as well. So thank you, everyone, for joining, and we look forward to the next Hot Topics. Bye.